Bismillahirrahmanirrahim. I'm Dr. Abdul Rahman and we are learning ECG. In this video, we will read about QRS complex, and we know that QRS complex demonstrates ventricular depolarization in an ECG. Let's go back to our original photo, which we have been discussing for a long period of time. So I will go through the some of the basics of ECG quickly before reaching to QRS complex in detail. So we know that ECG is graphical representation of electrical activity of the heart. So P wave is actually demonstrate atrial depolarization, then PR interval is demonstration of AV nodal delay, then Q wave is demonstrating septal depolarization, and then QRS complex is actually ventricular depolarization, followed by T wave, which is ventricular repolarization. So this is the basic knowledge which we already have. Let's discuss QRS complex in detail in our whiteboard. So this is the QRS complex. So a QRS complex is important in two aspects. So we have to look at the height of QRS complex and at the width of QRS complex. Okay, as far as width of QRS complex is concerned, QRS complex so on the basis of width, it is regarded as a broad complex or narrow complex. Okay, it can be broad complex, it can be narrow complex. So what is the cutoff of a broad and narrow complex is 100 to 120 milliseconds or 3 small squares. Okay, so usually whenever some QRS complex is more than 100 milliseconds, almost 2.5 small squares, then we usually label it as a sort of broad complex rhythm. But in some people it can be even wider, up to 120 milliseconds. So 120 is an absolute cutoff of the width of QRS complex. Something, if QRS complex is more than 120 milliseconds, it's 100% wide complex rhythm, and if it is more than 100, so mostly it is wide complex, and we can say that there is some sort of interventricular delay in conduction. If it is more than 100, usually it should be less than 100. And narrow complex rhythm, whatever QRS complex is less than 100, we will regard it as narrow complex QRS complex. And narrow complex, there is no lower limit of being a narrow complex rhythm, narrow QRS complex, because narrow is just normal. So whatever we read in a narrow QRS complex, it will be some normal electrical activity of ventricle. There will be no abnormality. But in case of broad complex, if the rhythm in the broad complex will be abnormal, we will be showing abnormal ventricular activity or some sort of delay in ventricular conduction. Okay, so this was the width of our QRS complex. And as far as height of QRS complex is concerned, the normal height of QRS complex is about 2.5 to 3 millivolt, and we know that 10 small squares is equal to 1 millivolt. Okay, so 2.5 to 3 millivolt is equal to 25 to 30 small squares. Okay, so this is the normal height of QRS complex. Any height more than 30 small squares, like 35 small squares, it will be too high, and this shows too much voltage, and this shows some abnormality in the ECG. Okay, and similarly, if the height is less, mean for example 10 millivolt mean 1 millivolt mean almost 10 small squares. This will be small height of QRS complex. Okay, and this will show different type of abnormalities. So as far as height is concerned, if it is more than 30 small squares, it is abnormal. And as far as width of the small square, if it is more than 3 small squares, it is abnormal. Okay, you can remember the number of 3 and 30. Okay, so let's take them one by one. First of all, narrow complex rhythms. Okay, narrow QRS complex. So let's draw our heart. We know that this is our heart, this is our SA node, this is our AV node. Impulse starts from SA node and reaches AV node after depolarizing the atrium, and then there is some AV nodal delay, and then it depolarizes the septum, followed by ventricular depolarization, and our QRS complex is formed during ventricular depolarization. Okay, so and what happens from here to here? P wave is formed. What happens here? PR interval is formed. What happens here? Q wave is formed. So it means that as far as there is no abnormality in the ventricles, as far as ventricles are okay, QRS complex will be okay. Okay, whenever there is a normal conduction from atria to ventricle, and what do I mean by normal conduction? Normal conduction means any conduction starting anywhere above AV node. It can be in the atria as a node, it can be in the atrium, it can be in the junction, wherever any conduction which started above the level of AV node, and that impulse passes through AV node, and after passing through AV node it is distributed to the ventricle. This is a normal conduction pathway, and whatever conduction happening in this way, the resultant QRS complex will be narrow, because this is following a fast conducting pathway of the heart. This is a fast conducting pathway. Okay, if any conduction is not passing through this not following this path, or some conduction is happening from this side, or there is a focus in the ventricle and conduction is due to this focus, there is some impulses being conducted, and that will lead to an abnormal QRS complex, which will be, in other term, will be broad QRS complex. So what are different rhythm in which the QRS complex will be narrow? And we can name it as just like normal sinus rhythm. QRS complex will be narrow. In case of sinus tachycardia, atrial tachycardia, junctional tachycardia or junctional rhythm. Okay, junctional, sorry. Then atrial fibrillation, atrial flutter, SVT, and in SVT we remember that it was of two types, AVNRT and AVRT, and AVRT was further of two types, ortho and antidromic, and orthodromic type of AVRT will be having narrow complex, because orthodromic, we remember, orthodromic was entering from here and exiting from the accessory pathway. Orthodromic, so AVNRT, orthodromic type of AVRT, all these rhythms will be having narrow complex rhythm, and they will be, if there is a tachycardia, it will be narrow complex tachycardia. Junctional rhythm, junctional tachycardia, SVT, normal sinus rhythm, sinus tachycardia, atrial flutter, atrial fibrillation, all these rhythms will be narrow complex rhythm or narrow complex tachycardia, and QRS complex will be narrow because these type of abnormalities or normalities are above the level of AV node. Okay, if it is above the level of AV node, QRS will not be affected. Okay, so now let's read about broad QRS complex. Broad QRS complex. So which condition will lead to broad QRS complex? Any condition in which, number one, the normal pathway is not being followed. In which a normal pathway is not being followed, or there is or conduction starts below AV node. And these are the two conditions in which conduction, in which normal, basically the overall concept is normal pathway is not being followed. Whenever there is an abnormal pathway is being followed, abnormal pathway is any pathway in which impulse enters in the ventricle. Again, any pathway in which impulse enters in the ventricular not from here, not from here. This is a normal pathway. This is a normal pathway. Any other pathway, if the pathway is from here, this is abnormal pathway from here, this is abnormal pathway from here, this is abnormal from here, this is abnormal. So any pathway which is not following a normal pathway will lead to broad QRS complex. So what are those conditions? So first of the condition I will discuss is antidromic AVRT. Remember what happened? What happened in antidromic type of AVRT? This was our heart, this was AV node. So in antidromic AVRT, impulse was entering from accessory pathway and it was exiting from AV node, and then it was entering from accessory pathway, and then again it was exiting from AV node. So this was the direction of the pathway. So when impulse enters here and it goes back to the AV node, what will happen? Because we know that our conducting tissues, which include SA node, AV node, Purkinje fiber, these are the fast conducting tissue. They are fast conducting tissue. Why they are fast conducting tissue? Because they have a lot of gap junctions, okay, which are lacking in ventricular tissue. So when impulse enters in the ventricular tissue, in the ventricular muscle, impulse will be slow, and then it will be slowly depolarizing in the ventricle. It will slowly go back to the AV node. This portion might be fast, but again it is slow. So this slowness will lead to a broad complex rhythm or broad QRS complex. Okay. So first example of broad complex rhythm is AVRT of antidromic type, because it is following a different pathway. Okay. And what was the second example? Again, let's draw our heart, and in this photo, this is SA node, this is AV node. We know that SA node impulse comes to the AV node. AV node there is some delay, and then there is bundle of H, and there is right bundle branch, and then there is left bundle branch. Okay. What happens normally? For example, when impulse reaches here, it depolarizes both of the ventricle at the same time. So this was depolarization of the right ventricle, and this was depolarization of the left ventricle. Okay, so right ventricle and left ventricle were depolarized at exactly the same time. That is why both QRS complex of the ventricle were overlapping each other, and the overall resultant QRS complex was in the form of this black. Okay. So this is the resultant QRS complex. But what happens if both are not conducted at the same time? Let's take this separately here, okay, and I will show you something. So for example, if left heart, if left ventricle is conducted earlier than the right ventricle, or if left ventricle is conducted later than the right ventricle, there are two conditions: either left is being depolarized earlier or left is being depolarized later. In either case, you will see that in this case, if left is depolarized earlier, what type of QRS complex we will be getting? The overall it will be like this shape. Okay, and similarly, if it is on the other side, again there will be a different shape, and that will be a notched QRS complex, and the notched QRS complex will be automatically broad QRS complex. And what happens? What is this condition? This is the condition which we see in bundle branch blocks. Bundle branch blocks. So what happens? Again, let's form our heart. SA node, AV node, impulse reaches here, bundle of his right and left. So if right bundle is blocked, then the left ventricle will be depolarized earlier. Then impulse come to the right side because this is blocked, and then right bundle will be blocked, will be right side will be depolarized. So what will happen? Left will be depolarized earlier and right will be depolarized later on. Similarly, in case of when left bundle is blocked, then right will be depolarized earlier and left will be depolarized later on. So this causes a delay. Again, there is a disruption in the normal pathway of the conduction. Normal conduction pathway is disrupted. They are not being depolarized at the same time, so that will lead to a broad complex tachycardia. So first it was AVRT, second it is bundle branch block, which is left bundle branch block and right bundle branch block. Okay, and third condition, hyperkalemia. Remember what was happening in hyperkalemia? So we know this is our normal depolarization curve of a ventricle. So sodium was entering here, and there was a plateau in which calcium was coming in and potassium was going out, and then potassium was going out, which will lead to again repolarization. And what happened in hyperkalemia? We remember that when there is too much, this is our cell, when there is too much potassium outside, it will come inside, and inside of the cell will be filled with potassium. Okay, and this high concentration of potassium will lead to less sodium going inside. If less sodium will go inside, what will happen? If this sodium will be less due to hyperkalemia, what will happen? Instead of a steep curve, it will be like this. The depolarization will be like this, and this type of depolarization will lead to again a broad complex rhythm in case of ventricles. And similarly, if in case we are discussing the same curve in case of atria, and in case of atria, if it is steep, the P wave will be flattened or P wave will be lost. So in hyperkalemia, we know that there are some other features as well, but two of the features are broad QRS complex and loss of P wave. So the third example of broad QRS complex is hyperkalemia. Okay, and what is the so we have read about orthodromic orthodromic conduction, bundle branch block, and hyperkalemia. And fourth example is sodium channel blockers. Sodium channel blocker will also act in the same way. If we are taking some drug which blocks sodium channel, which will lead to less sodium entry into the cell, and this less sodium entry into the cell will again lead to a slopy appearance. Instead of steep, there will be a slopy depolarization, and which will again lead to broad QRS complex. So fourth is sodium channel blocker. Okay, so fourth cause of broad complex is sodium channel blocker. And fifth and very important cause is pacemaker. We will read in detail about pacemakers and all that, but for now I just want you to get an idea about how pacemaker works. Usually pacemakers, why we put pacemaker? Actually, pacemakers are the devices which give some stimulus to the cardiomyocytes for a better conduction. Okay, so most of the pacemakers are placed on the right side of the heart. So for example, this is a pacemaker device. Usually it have leads. It can be a single lead, it can be a dual chamber pacemaker, or it can be a biventricular pacemaker. Okay, there are three types of pacemaker: single chamber, dual chamber, biventricular pacemaker. Okay, single chamber pacemaker, it can be only, it's having only one lead. It can be only in the atria, the right atrium or right ventricle. Why right? Because SC and AV node are on the right side, and second, they are easily accessible. And dual chamber pacemaker, they have leads both atrium and ventricle, both are right side. And third type of pacemaker is the biventricular pacemaker, in which we have two leads, both on the right as well as on the left side of the heart. Biventricular pacemaker. So which type of pacemaker will lead to broad complex rhythm? The single chamber pacemaker and dual chamber pacemaker. Okay, single and dual chamber pacemaker, and these are usually these type of pacemaker give a broad complex rhythm. And among single chamber pacemaker, right ventricular pacemaker, right ventricular single chamber, or dual chamber, which include both right and left, right atrium and right ventricle. So basically the main thing is right ventricle. So right ventricular pacemakers will lead to a broad complex rhythm. What pacemaker does? Usually pacemaker depolarizes the right side first. Okay, so when the pacemaker, when there is a right, when there is single chamber pacemaker or dual chamber only on the right side, so right side will be depolarized earlier and then it will depolarize to the left side. So this will make an LBBB type of effect, because pacemaker is on the right side and right side of the heart will be depolarized earlier and then the left side of the heart, and exactly same was happening in left bundle branch block, where right side of the heart was depolarized earlier and left side of the heart was depolarized later on. So this is a type of pacemaker in which we will see an ECG which looks like LBB, left bundle branch block, but it is not a left bundle branch block, it is a pacemaker rhythm. Okay, I will show you the ECGs at the end, and then you will get an idea. And why in biventricular pacemaker it is there is no broad QRS complex? Because in biventricular pacemaker we have leads in both of the ventricle, in right as well as left ventricle. Okay, and in these type of pacemakers they depolarize both the ventricle at the same time. Okay, and that is just a normal thing. Okay, in case of biventricular pacemaker there is no broad QRS complex, there is only narrow QRS complex. Okay, so these were some of the causes of broad QRS complex. Starting from the beginning, abnormal conduction, that is from AVRT, orthodromic, antidromic type of AVRT, hyperkalemia, sodium channel blocker, and pacemaker potential. Okay, and fifth one is bundle branch block. Okay, so now let's read about something about the height of QRS complex. So in which condition the height of QRS complex will increase? And there is a well-known condition called hypertrophic cardiomyopathy. Either so it's not like basically not hypertrophic cardiomyopathy, sorry, this is left ventricular hypertrophy. It's not cardiomyopathy, because in hypertrophic cardiomyopathy usually there are deep cubae, which we have already read about that. Left ventricular hypertrophy. So what happens in left ventricular hypertrophy? So it will be like this. Okay, so left ventricle will be hypertrophied, most likely due to persistent or chronic hypertension. You will lead to hypertrophy of left ventricle. When there is left ventricular hypertrophy, they will, and then what will happen? You remember, the vectors will be big vectors, huge vectors. Okay, and this huge vector toward the left side and huge muscle mass will generate a huge voltage, and this will lead to a huge QRS complex. Okay, huge QRS complex. So the leads in which there is positive QRS complex, that will be more on the positive side, like V5, V6, and the leads in which there is a negative QRS complex, it will be more on the left side, a deep S wave, for example V1 and V2. And we have something called voltage criteria of LVH, in which we add S wave in V1 plus R wave in V6. So we add S wave in V1 and R wave in V6, and if the addition is more than 35 small squares, if the addition is more than 35 small squares, which equal to 3.5 millivolt, then we will regard it as left ventricular hypertrophy. So in left ventricular hypertrophy, you will see huge QRS complexes either on the positive side or negative side. And in V5, V6 or lead 1 AVL, they will be on the positive side, and V1, V2, they will be on the negative side. Okay. Yes. And in what condition the QRS complex will be? In less voltage, any condition in which the conduction from the heart itself is not reaching up to the lead. For example, this is the heart and this is the body. Okay. If there is a condition, if this is a normal condition, it will reach to the body very easily and there is a normal ECG. But if there is a condition in which there is a bag around the heart and heart is filled with some water around the heart, and the impulse generated in the heart is finding a difficult time to reach to the surface. If you find difficult time to reach to the surface, what will happen? The voltage will decrease because the heart is wrapped around a big bag or balloon or something which is causing a disruption between heart and our ECG electrodes. Then that will lead to smaller QRS complexes. And what condition? It is called pericardial effusion. Okay. And pericardial effusion, there will be a big bag of water around the heart. In pericardial cavity, there is some fluid which causes decrease in amplitude of QRS complex. And there is something called electrical alternans. What happens in electrical alternans? You will see one big QRS complex, one small QRS complex, one big QRS complex, one small QRS, one big QRS. So this is a pathognomonic factor of pericardial effusion. Pericardial effusion, there will be an electrical alternans. So what happens actually, there is a big pericardial effusion. So heart is actually hanging like a pendulum in the effusion. It will go like this, like this, like this, like this, like this. So when it is coming toward the skin, it will lead to big QRS complex. When going away from the skin, it will lead to small QRS complex. When coming to the skin, big QRS complex. When going away, small QRS complex. So that is why there is an electrical alternans in pericardial effusion, a big and a small QRS complex. So these are some of the important abnormalities of QRS complex which we can encounter in our ECGs.